So in room 1 we have Julie Marks. She is recently been diagnosed with emphysema. She's a 58-year-old female and she identifies as Indigenous. Now she has a history of smoking where she smokes a pack a day and she started when she was 19. She works as a delivery truck driver and her father has a history of emphysema and died of heart failure. Now we haven't been able to make a full assessment of Julie yet and she's going to require a lot of education.
Hi Julie, how are you going?
Good, thanks.
So I'm your nurse for today and I'm just going to do some obs if that's alright.
That's fine.
Alrighty, so I'll just check your blood pressure. Alright, so you have an increased blood pressure. And I'll check your pulse. Yeah, so you have an increased pulse as well. I'll check your O2 stats. Yeah, so you have a decreased oxygen saturation. And I'm just going to do your respiratory. Yep, so you also have an increased respiratory rate. So I'm just going to have a listen to your chest. So I'm hearing some hyperresonance. It's a really loud sound. It's a low pitch with a long duration. You've got a longer expiration than an inspiration, and on the expiration I am hearing some wheezing.
Hi Julie, so you've been recently diagnosed with emphysema.
Yeah.
Do you know much about emphysema?
No, I don't really understand it at all.
Oh, okay. I'll just spend some time with you now just to explain a little bit more about it.
Okay, thank you.
So now I'll just explain a little bit about emphysema. Okay, so emphysema is a respiratory condition that can be defined as a destruction of the walls of the alveoli, resulting in a permanent increase in the airspace size. So I'll just go through why this occurs. So for you, this process starts because you're cigarette smoking, and it causes the inflammatory response. So from that, lysosomes of phagocyte cells, mainly neutrophils, release elastase into the lungs. And in normal lungs, the elastase is inhibited by alpha-1 antiproteases. However, in a smoker, this can be inhibited. And also hereditary conditions such as alpha-1 antiproteases deficiency may be present in you as well, given your family history of your dad having emphysema as well. This condition is present along with tobacco smoking. The amount of circulating elastase in the alveoli increases. Therefore, the production of elastase outweighs the effect of alpha-1 antiproteases, which causes the destruction of elastic tissues in the alveolar sacs, hence leading to the destruction of the alveolar walls and the loss of elastic recoil in the bronchi, and together they cause emphysema. Following on, the destruction of the distal air sac walls leads to a range of complications within the body. The loss of alveolar tissue means the loss of a respiratory membrane where gastric exchange occurs. This causes a significant mismatch between ventilation and perfusion coupling, as there is inadequate supply of oxygen, causing hypoxemia and hypercapnia. Hypoxemia can cause agitation, hypertension, tachycardia, tachypnea, altered mental status as well. Hypercapnia can then lead to respiratory acidosis. Furthermore, the increase in pressure in the alveoli compresses the capillaries in the alveolar walls, resulting in pulmonary hypertension. Pulmonary hypertension then leads to right ventricular hypertrophy and right heart failure. As emphysema progresses and becomes more severe, large cyst-like areas may form, called bullae. These cysts may rupture and cause pneumothorax. As the bronchioles lose their normal elastic recoil, along with other factors of chronic bronchitis, air trapping is a main characteristic of emphysema. Air trapping can cause a barrel chest, making the chest hyperextend due to the increased residual volume. In a normal alveoli, there's lots of little tiny air sacs, and they're in good condition, whereas in the alveoli with emphysema, there's lots of large air sacs, which is the decrease in surface area and a decrease in the characteristics of the respiratory membrane, making it less favourable for gastric exchange. In a normal state with a person who does not have emphysema, they have no chronic inflammatory response, the alveoli is not damaged, the respiratory membrane is in good condition and is not damaged, they are not deficient in alpha-1 antiproteases, They are not deficient in elastase to allow for the stretch and recoil of the alveoli. The bronchioles do not collapse with exhale. The normal respiratory drive is driven by the concentration of carbon dioxide in the blood, and their oxygen saturation is above 95%. So in a dysfunctional state with a person with emphysema, they have chronic inflammation of the bronchioles and alveoli. They have impaired gas exchange. They have hypoxemia and hypercapnia. They can develop respiratory acidosis. They could develop hyperventilation. They could experience air trapping. They also have a reversed inspiratory drive, so it's driven by the concentration of oxygen in the blood, not carbon dioxide. They have an increased residual volume, so when they breathe out, there is more air left in the lungs still. They have a barreled chest, which can lead to hypoventilation. They have an increase in pulmonary artery pressure, and they are more at risk of developing heart failure. And it can be seen that they're using their accessory muscles to breathe, and they have a decreased oxygen saturation below 95%.
That makes so much more sense now.
Oh, you're welcome.
Hi Julie, I'm your 8 o'clock meds now. We've got a bronchodilator for you, and we've also got a steroid.
Beautiful. Okay.
So I'll just go and grab them. Safety and Quality Health Services Medication Safety Standard 4. We need to make sure we administer medication safely. In order to do this, we can remember the 7 rights. The first one is right patient. Second one, right dose. Right drug. Right reason. Right time. Right route. And right documentation. So Julie, I'm going to go through bronchodilators with you. So bronchodilators are used to dilate the airways and allow for respiration. They're good for the treatment of people with emphysema. The doctor's prescribed you anticholinergics, which is a type of bronchodilator. And this works by blocking the vagus nerve, which allows the bronchi to dilate. So what we've given you is tiotetraphomine bromide, and the indication for this is the treatment of bronchospasms associated with emphysema. Contraindications to this medication is tropamine, tropamine-derived rets, and hypersensitivity. Adverse reactions that may occur are an irritated throat, dry mouth and cough, skin rash and oedema, and paroxysmal bronchoconstriction, and in rare cases, constipation and urinary retention. You should only use this for safety considerations. You should only use this with caution if you have predisposition to bladder neck obstruction, glaucoma, urinary retention, prostatic hypertrophy, moderate to severe kidney impairment. Also, a caution if using another anticholinergic. Another consideration is that Julie probably doesn't know how to use a hand inhaler, so the nurse will need to teach her. With monitoring, we need to monitor for contraindications and cautions to the allergy in the health history. We also need to do a set of vital signs before and after the administration to determine the effectiveness. Before and after the drug is administered, it is also important to assess skin colour, orientation including reflexes, evaluate respirations, and evaluate urinary output. One drug that we can use is inhaled steroids. Inhaled steroids have been found effective in treating emphysema when used in conjunction with the bronchodilator. So the action of this is it decreases swelling and promotes smooth muscle relaxation. So an indication for this is treatment of COPD. Contraindications include emergency situations, pregnancy and breastfeeding unless the benefits outweigh the risks, an active infection. Some adverse effects include hoarseness, sore throat, cough, dry mouth, irritation of the throat and mouth, oral candidiasis, paroxysmal bronchospasms, and hypersensitivity. Some safety includes making sure that the patient is stable before administering medication. Monitoring and assessment is necessary, and a caution should be taken when going from oral therapy to inhaled therapy. So monitoring includes monitoring for possible contraindications, performing a physical assessment before and after administration. It's also really important to check the temperature, and taking a set of vital signs before and after.
I understand that you're a smoker. Yeah. Have you ever tried to quit?
Yeah, but nah, I haven't. Like, I just don't know where to ever start, and I really wanted to. I don't know how.
Yeah. So it's really important that we get you to try and quit smoking, just especially with your condition with emphysema. It can really be a bit harmful, but also just for your general health, it's really good to stop. So I have a few methods and steps if you want, and we can try and help you stop smoking if you're interested.
Oh, that'd be brilliant.
Alright, awesome. So our first step is to refer you to a smoking cessation service, such as like Quit. Have you ever heard of it?
Yeah.
Yeah. So I'm going to give you this pamphlet. This is their website, so you can access it any time. They also have a hotline. It's actually the most effective route to stop using one of these services. However, most people don't utilise it, so it's a great resource for you to have. Other things we can offer for you as well is some pharmacotherapy, which is because it's been shown to be really effective when used with behavioural support and the medication as well. So the meetings you'll go to are sort of face-to-face meetings, and they'll be with people who've been trained in the smoking cessation service, or maybe people who've already quit smoking. They'll pretty much just give you some advice, some information, some encouragement, all those kind of things. The pharmacotherapies you can be using are nicotine replacement therapies, so they can help you sort of wean off that. But it's really important that you set an end date for when you're going to stop using these medications, so that you can make a commitment to slowly stop and end at that date and not continue using them instead of the cigarettes.
Thank you. Hi, Julie. We can see here that Julie is likely having an exacerbation of COPD. The indicators of shortness of breath is the tripod positioning, where she's trying to expand her chest to allow more oxygen to get into her lungs. Another indication is her use of accessory muscles to breathe. This is not an indication of passive breathing and shows that she's using active energy to breathe. I'm now going to get her oxygen saturations and see if she needs any oxygen supplied. As well as this, I'm going to stay with my patient because often with experiences of SOB, they can have high anxiety. So instead, if I need assistance, I will try and call in another nurse to assist me. Alright, Julie, I'm just going to check your oxygen saturations here. Can I please get some help in here?
Yeah.
Okay, just calm down, big deep breaths. Your oxygen levels are quite low, so I'm going to administer some oxygen. Deep breathing. Here we go. We must consider when giving oxygen to a COPD patient that if they're having an expiration of their COPD conditions, they're going to be given different oxygens used with different methods. COPD patient experiencing an exacerbation of COPD, such as shortness of breath, there are different methods of giving oxygen. Now, this is a nasal cannula. They give a rate of 1.4 litres per minute and can provide 22 to 45% oxygen. Now, although these are often used for COPD patients, they are not recommended when the patient is experiencing an exacerbation of COPD because they cannot be exactly monitored. Alternatively, there is another method which is the Venturi mask. Now, this mask gives 6.5 litres per minute and can provide at a rate of 24 to 60% and can be accurately monitored. So this is what is recommended for when giving oxygen for an exacerbation of COPD.
Medication that we have is oxygen. Now, oxygen may be required long term for patients with emphysema and other COPD due to severe hypoxia. Severe hypoxia is oxygen saturation below 88%. So an indication for oxygen therapy in COPD patients would be below 92% oxygen saturation, just chest wall configuration such as barrel chest, clinical signs of hypoxia, and diagnostic laboratory studies showing arterial blast gases and pulmonary function tests. Some contraindications is high rates usage with people with a reverse respiratory drive. Some side effects include hypercapnia and hyperoxia. Some safety to remember with using oxygen is to place cautionary signs on Julie's oxygen equipment, It is also important to educate Julie appropriately on oxygen administration and signs of hypoxia, and ensure that the correct oxygen is used, so 2%, which is the low oxygen rate, and you should always use with conjunction to measurement of hypoxia, such as a pulse oximetry machine. So monitoring includes the pulse oximetry machine, and it also includes other signs of oxygen status such as pulse, respiratory rate, rate and depth of breathing, colour of skin, anxiety level and level of consciousness. It's also important to inspect nasal prongs for any signs of pressure sores.
Flu vaccine for this year?
No, I haven't.
Alright, so we really recommend it for all COPD patients, obviously because you're more at risk with your lowered immune system, but also because obviously it'll really affect you and you already have a respiratory condition which is affecting your breathing. So we also really recommend it. If you do happen to get an infection, you'll probably need to come into the hospital and just get some antibiotics and just help you out there.
The next one we have is antibiotics. Now, due to increased risk of respiratory infections, antibiotics may be needed for emphysema patients at some stage. So the doctor's probably going to prescribe a broad spectrum penicillin. One example of this is amoxicillin. So the action for amoxicillin is it produces bactericidal effects. The indication for this is an infection of the lower respiratory system. Contraindications include allergies to penicillins and history of renal disease. Adverse effects may include hypersensitivity reaction, blood problems such as anemia and coagulation disorders, GI upset such as diarrhea, nausea, vomiting and abdominal pain, fever also may be included, and in rare risks, bronchospasms. For safety, the nurse should be aware that the blood-brain barrier permeability is increased with use. Staff should avoid oversensitising themselves to penicillin. Treatment should continue after symptoms disappear, and electrolyte monitoring may be needed with prolonged use. Monitoring includes assessing the contraindications, performing a physical assessment, obtaining before and after vital signs, examining the skin and mucous membranes, performing culture and sensitivity tests, and pay particular attention to respiratory status.
Today I want to talk to you about some coping strategies. Now these are really important in helping you managing your emphysema. Because if they're effective, then they can help you feel like you're breathing easier and help you with that. But conversely, if you're not quite good at them, you might feel some respiratory panic and distress. So that's why it's really important that we, have a go at these. Now, some things you do might, make it a bit harder for you to breathe. Some things take some effort. So it's really important to know your own limits. And it's perfectly fine to take some time out for yourself and sort of assess those, sort of alone, privately, so you're not worried about embarrassment or any that kind of things. But also, anything that you feel like might release some tension and relaxation. You can do yoga, anything you enjoy, knitting or sewing, anything that just really calms you down. Prayer, if you're religious or spiritual at all. Just having a good cry or, talking to someone about it, just feel like you always have someone to talk to. But really anything that just helps you relax and calm down is just going to be great for your breathing.
Oh, thanks. That really helps. Thanks.
Pulmonary rehabilitation has been recommended for patients with COPD as it relieves events of dyspnea, fatigue, and it can increase the patient's self-control over their disease. Pulmonary rehabilitation is a collaborative approach, including the work of physiotherapists. Now, what the nurse can do in nursing management is educating on teaching breathing exercises. Now, there's 3 different types of breathing that you can try. One of them is yoga breathing, pursed lip breathing, and diaphragmic breathing. Now, if we're going to try yoga breathing, this is long breaths, holding your breaths. Now, can you breathe in to the count of 3 and breathe out to the count of 3 in your nose?
Okay.
Right. Perfect. Now Now another one is pursed lip breathing. So this is where you breathe in through your nose and exhale slowly through your mouth while your lips are pursed, like you're blowing through a straw. Okay? And finally, we've got diaphragmic breathing, where you're breathing right into your belly and pushing that forward. And do big, deep, slow breaths again. Perfect. And you can also try that lying down. Another thing that's recommended is regular exercises. So, Julie, you can participate in daily exercises, including small walks. Start off with a small distance and then try and push yourself and go as far, but don't go further if you're feeling short of breath. Know your limitations and know where to stop. Any aerobic exercise is going to be good for improving your breathing and activity tolerance.
Thank you.